BiPAP ST titration, and it kind of, I think, folds into this, you know, obstructive and central sleep apnea. So I thought it'd be a good talk to kind of outline the disorders. And I think a lot of the big thing people struggle with are these different devices. So I thought it would be helpful. Go ahead and advance. Nothing major to report. I do have a small research project working with Philips where there's actually supporting a call center for COPD, but nothing relevant to this talk. Next slide. So I'm going to review the basic operations of bilevel therapy, identify sort of situations when these therapies should be implemented, and then I thought it'd be useful for non-sort of sleep people how we do these titrations of these different devices. And a lot of times we might even use these, you know, outside the treatment of obstructive sleep apnea, you know, whether it's chronic respiratory failure for whatever condition. So certainly useful to know. Next slide. So obviously, I think everyone's probably familiar with CPAP, which stands for continuous positive airway pressure therapy. So there's really no difference in the pressure delivered during inhalation versus exhalation. And really that's just that acting as that pneumatic stent to keep the airway patent, you know, most commonly during sleep. Bilevel, on the other hand, delivers a higher pressure while you're breathing in and a lower pressure while you're breathing out. So, you know, many times in the sleep apnea patient, we might use that if they really struggle with sort of breathing out against continuous pressure. It's really more of a kind of comfort measure when we implement bilevel. But, you know, we will use bilevel in other situations because you're really not only stenting open the airway, but with that IPAP or pressure support you're giving them, you are sort of augmenting ventilation to an extent. Next slide. And this just shows it graphically where, you know, CPAP, you might dial in a CPAP at 10, and that's the pressure they get whether they're breathing in or breathing out, where you can see with BiPAP, you'll have an inspiratory pressure that might be 10, but then you'll have an expiratory pressure, which might be 5, 6, whatever. So there's a difference there. Next slide. So the IPAP really acts to reduce the work of breathing. It offloads the workload on the respiratory muscles, particularly your accessory respiratory muscles, where as I mentioned, the EPAP really functions to maintain patency of the upper airway and to control, you know, obstructive apnea and improve, and it can improve your functional residual capacity. So this gradient between the IPAP, which again is your inspiratory positive airway pressure, and the EPAP, which is your expiratory positive airway pressure, that difference is the pressure support window. Next slide. So bilevel ST, so that's the difference between CPAP and BiPAP. But what's the difference between, you know, simple bilevel ST or spontaneous and bilevel ST, which is spontaneous or time? So bilevel S and auto bilevel therapy require the patient to initiate a breath, so they do not provide a backup breath rate. Where BiPAP or bilevel ST allows the patient to initiate a breath, sort of that's spontaneous, but also deliver a breath of over a certain amount of time after it's passed, and you might, you know, even dial that in. So that's where that timed breath comes in. So, you know, if you give someone a backup breath rate of 10 and they don't breathe on their own, you know, every minute they're taking 10 breaths, so they'll get a breath every 6 seconds. So time will trigger the breath. So a provider may specify a backup breath rate of 10, as I said, and then, you know, that'll give one of these sort of quote unquote IPAP breaths. Next slide. So this is an EPOCH with bilevel S. So as you can see, this is sort of your classic representation of a central apnea. So in the CPAP signal, this is airflow, there's absolutely no airflow. You guys can see that, I'm sure. Where and then these chest and abdominal RIP belts, which are respiratory impedance belts, they don't sense any respiratory effort. So they're completely flat. So you guys can see how all of those signals are flat. So that would define a central apnea. An obstructive apnea, you wouldn't see any airflow, but you would see the chest and abdomen moving because there would be ongoing respiratory effort. The airway would just be completely shut down and collapsed, and so air couldn't move in and out, despite the patient making an effort to do so. And a lot of times you might see it's actually very vigorous, where the patient's really working to try and pull that air into their lungs, and it's just not working because their airways collapsed. But again, in this case, there's no respiratory effort whatsoever. So this gets away from really, an upper airway problem per se, and more of a brainstem respiratory center problem. The signals from the brain that control breathing aren't outputting to the respiratory muscles. So in this situation, using a CPAP or a BiPAP-S isn't going to do anything, right? Because if the patient's not breathing, it's not going to deliver any support, right? Particularly with that IPAP breath. So how do you, make this patient, how do you support this patient's breathing and make sure they're, receiving adequate minute ventilation? Next slide. We put them on a BiPAP ST mode. So actually, could you go back to that last slide? So you can see here, they're really just in a CPAP mode. It says CPAP at the bottom, but they're really in a BiPAP mode. But, it's not triggering. You probably have them on, BiPAP 10/6, but that it's really not triggering any breaths because there's no patient effort. And you move to the next slide, and you can see that, there is that has all resolved as the patients, as the machine is actually kicking in to deliver those breaths. And when you see dips in the flow and effort, that's when you can tell that there's a breath that the patient's giving. And then if there's no, say this patient didn't have a breath in 6 seconds, that's when the bilevel might know, hey, it's time to give them a breath. They haven't triggered one on their own. Next slide. So when we're, again, considering people for bilevel titration, many times in the sleep apnea patient, we'll do it if they're uncomfortable and intolerant of the high pressures. And if they have continued respiratory events when they're on a CPAP pressure of 15, we may also switch them to bilevel. And that's because, really when you get to those higher pressures on CPAP, it can be really difficult to sort of tolerate those high pressures. And a lot of that's up to many times the tech's judgment or respiratory therapist or sleep tech's judgment, how well a patient's tolerating CPAP or BiPAP. But many times we will switch them to BiPAP at higher levels, just because particularly PAP naive patients, it can be very difficult you almost feel like you're in a wind tunnel if you put the pressure too high. So on average, when you switch someone from CPAP to bilevel therapy, the mean airway pressure actually decreases. And then sometimes what we'll see is when we're doing one of these bilevel titrations is they'll get over titrated. So there's kind of two phenomenon that you should be familiar with as far as obstructive sleep apnea goes and the development of central apnea. One is if patients get over titrated, the pressure is actually made too high, you can actually induce central apnea through a number of mechanisms. One's glottic braking and one's increased CO2, more efficient CO2 removal, sort of blowing their CO2 down below their apneic threshold. So we see that actually fairly commonly. There's also a phenomenon called treatment emergent central apnea, where you treat their obstructive apnea and then you see the emergence of central apnea. And a lot of times that actually will go away on its own. And again, the leading theory is it gets back to sort of CO2 homeostasis during sleep. And as you sort of relieve the obstructive events at night and open that airway, the patient's probably more efficiently removing CO2, and you sort of blow the CO2 down to an extent that's below their apneic threshold. And a lot of times what you'll see, and what our practice is we'll just keep them on that therapy for 2 or 3 months. And many times you'll see the central apnea resolve actually when you're just with simple CPAP or bi-level therapy. Next slide. So when we're starting someone on CPAP when we're starting someone on BiPAP, we usually start someone 8/4, particularly in pediatric patients. And, I tend to try and start people lower because I think if you start them too high, it really, it does take some getting used to, particularly if they're naive. Now, this is a little bit different than the hospital. When someone's in the hospital, in a CHF exacerbation or COPD exacerbation, this typically isn't going to be adequate. And, I wish I could give you some specific numbers to consider. Really, it's just making a clinical judgment based on the patient's size, what their CO2 level is, what their oxygen level is. So, really I just kind of, when I'm starting someone in the hospital for one of these disorders, I really just kind of look at the clinical situation and then, decide, do they need 10/5, 12/6, 14/10? It's kind of really dependent on the patient. I usually try and get a sense if they have a history of sleep apnea that's complicating things, and then that if they're on CPAP, that can be a useful starting point if you want to, if you're trying to guess what to put these patients on. The recommended IPAP for pediatric patients is less than 20, and then you can go up to 30 for, adults. Next slide. And this just sort of outlines when we increase both the IPAP and EPAP during a titration study. And again, this is for patients with obstructive sleep apnea. One of the things that, I try and, it's really a fine balance between being too aggressive and over titrating someone, but then you also worry when techs aren't aggressive enough and you actually don't get things optimized by the end of the study. So it is a really fine balance. I remember when I was a fellow, I'd always be like, why didn't they do this? And then during my sleep fellowship, I had to do, a couple titration studies. It's kind of hard to do while you're just doing it on the fly, looking at the patient, making sure that they kind of stay comfortable and everything. But thankfully at WVU, we've got some really good techs who help us. So obstructive apneas, just for your guys' knowledge, that's when you have sort of almost complete loss of flow. It's at least 90% drop in flow for at least 10 seconds. Hypopneas are kind of less, a smaller decrease in flow defined by at least 30% decrease in flow. It lasts about 10 seconds and it's associated with a desaturation. Respiratory event related arousals are, they're not technically scored in all sleep studies, but if someone's having a lot of these respiratory events that don't quite meet the criteria for hypopnea or apnea, that's when we may increase someone's IPAP to see if that helps get better sleep efficiency during the night. Next slide. And this is just sort of an algorithm on how we titrate these patients, you know, through the night, looking at the number of events they have. And then when we sort of up titrate each one of these different settings, and this is essentially what we do in our sleep lab. The only difference I have in our sleep lab is this, instead of going up, and now this is in adults, a centimeter at a time, I have our techs do 2 centimeters of water pressure at a time, just because I think it gets patients to therapy more quickly. Next slide. And so I think one thing we always got to make sure of in medicine is, you know, you have your optimal treatment, what's going to work best. And, you know, unfortunately, we have to deal with this a lot in medicine. And then, you know, with healthcare disparities, you know, we are always looking for ways to make patients better. But, you know, unfortunately, we always struggle getting people the optimal therapy they need. You know, in the sleep medicine world, ideally, we get someone's apnea below 5 events per hour, you know, hopefully for at least 15 minutes on the final pressure that we prescribe for them. And, you know, we maintain their oxygen saturations. Patients' sleep apnea is typically worse in REM and on their back. That's when people are at their worst. Remember, when you're in REM sleep, you're paralyzed. So the only muscles that work are your eye muscles, your ear muscles, and your diaphragm. So the rest of your muscles that sort of maintain airway patency are paralyzed during that time. Then when you lay on your back, you can imagine that your apnea would be worse. Next slide. And this is very important, I think, in a lot of you know, diseases, but you know, obviously in obstructive sleep apnea, you know, sometimes our techs will just ramp someone up and they get their apnea hypopnea index down to 0 and completely eliminate their apneas. But you have them on such high pressures, the patient's never going to use their machine. So what good is that, right? So if you're giving them something that they're never going to use, that's not very effective treatment, right? Next slide. So we have, you know, the definition of a good bilevel titration. That's where we get the, you know, level less than 10 or by 50%. I mean, I certainly have patients who are, you know, very obese, have a lot of upper airway compromise, and they might have an apnea hypopnea index of, you know, 110. Well, I get their AHI down to 25. I actually call that a win. Particularly because, you know, the pressures that would be required to control their apnea they would never tolerate. So sometimes you just have to make that call when you're titrating these patients. Next slide. And this is adequate. And again, it's just getting their AHI reduced by 75% from baseline. And again, always optimal if you can have supine and REM sleep supine REM sleep at the selected pressure. Next slide. So I think it is important to be familiar with your local protocols. And, you know, I allow our techs, because most of them, you know, we're lucky, most of them have a respiratory therapy background. So they're very comfortable with, like, you know, ventilation type modes. Yeah, you know, we do a lot of actually AVAPs, which is really a volume assured pressure support. That's really what we do most of our COPD patients with now, or, you know, neuromuscular patients. We, instead of using like a BiPAP ST, we really dial in a tidal volume and try and control their minute ventilation. When we're putting someone on therapy for central or complex apnea, first and foremost, they have to have the correct diagnosis. So sometimes techs will actually overcall central or complex apneas, and they won't have a central apnea index greater than 5. So they'll put them on a BiPAP ST mode, but not really qualify for it, and they actually really won't need it. One caveat to know, no matter what sort of mode you're putting someone on, when you get an NIV therapy where you add a backup breath rate, just that small addition adds thousands and thousands of dollars to the device cost. So, you know, A BiPAP machine might be like $500 bucks. A BiPAP ST is like $3,000. So it's a big, big difference in cost for these patients, and for people particularly with sort of scarce resources. And if they really need it, they need it. But if you can get away with a BiPAP S, or that's really what you should do. And then when you're sort of considering treating these patients, you always got to make sure you're treating their sleepiness. Or is their sleep getting more consolidated, or are they still waking up? How are they feeling in the morning? Has their snoring resolved? Or are they still having apneas? And then a lot of times, we want to assess whether they're having daytime or nocturnal hypoventilation. One big problem in West Virginia is obesity hypoventilation syndrome. I was just putting in a grant this last week, and I was looking at our obesity rates, and unfortunately we still lead the country, and we're almost up to 40% of our population is overweight, which is kind of scary. Always consider obesity hypoventilation in your differential, and those patients actually many times will have some central apnea as well. Next slide. There is some fine tuning that you can do. I think many times, the technologists are the ones that are really good at doing this on NIV. And I will say, most of my colleagues who are non-sleep actually don't get into the fine tuning of, these machines when they're trying to troubleshoot them with the patients. But I do think it's worth knowing, and what you could, potentially intervene on. The rise time is the amount of time it takes to go, and those of you who are familiar with invasive mechanical ventilation, a lot of these things are the same. The rise time is the amount of time it takes the device to change from the expiratory pressure to the inspiratory pressure, and this can vary based on the manufacturer, and the values really correspond to 1/10 of a second. So if you have a setting of 3, that's 0.3 seconds. Some machines actually will do it in milliseconds, but some patients with like obstructive lung disease may prefer a faster rise time, so you get to that IPAP quick, and then they have plenty of time to exhale because they have obstructive lung disease and can get air trapping and things. So the more time they have to exhale, the better. Next slide. The inspiratory time is the amount of time the device actually spends at that IPAP. So how long the rise time is how quickly you get to that level. The inspiratory time is how long you stay at that level. So the goal is to really choose a setting that allows synchronization between the patient and the device. If it's too high, the patient may have inadequate time to exhale completely. If it's too low, there might not be sort of adequate time for gas exchange to occur. Sometimes you can see a little blip in the IPAP where the machine cycles off, but the patient's still trying to breathe in, and it's similar on mechanical ventilators too. Next slide. Then there's fine tuning you can do with the trigger and cycling. So the trigger is what change in flow initiates the breath. So this is the patient actually initiating the breath. So the higher sensitivity means lower flow changes. So, a lot of times in our neuromuscular patients, ALS patients, they can't generate a lot of flow. A lot of our end-stage COPD patients have the same problem where they just can't take that big, deep enough breath to actually trigger one of these machines to deliver the respiratory support. So we might have to make the trigger sensitivity a little higher or more sensitive so they can generate flow. And then the cycle sensitivity is the change in flow that initiates sort of exhalation or cycling over to that EPAP after the flow is delivered. And essentially what it looks at is, depending on the sensitivity you put it at, it looks at what was the patient's peak flow. And then usually medium, like the medium default setting, once you hit 25% of peak flow, it kind of shuts off, cycles off, and lets the patient exhale and go to the EPAP. So next slide. And these are kind of some default settings. And these are what most these machines come with, but you know, again, you can modify these based on, you know, what the patient needs. Next. So you have a 48-year-old morbidly obese gentleman presented to your sleep center for a trial of positive airway pressure therapy. He has a baseline apnea-hypopnea index on an out-of-center sleep test of 53. A new tech asks you to look at the raw data and assess his titration. He is excited because he identified complex apnea that was well controlled with BiPAP ST. Just so you guys know, you know, really how we the basis for apnea severity is this apnea hypopnea index number. So essentially what we do is add up all the respiratory events they have during the night and then divide it by the number of hours they slept, if it's based on a in-lab sleep study or polysomnography, or if it's an out-of-center sleep test, it's how long they sort of wore the device. You know, less than 5 we say is normal. 5 to 15 is mild, 15 to 30 is moderate, and then greater than 30 we call severe. And the reason that's important is there's, you know, fairly good data. You start seeing an uptick in adverse health outcomes at that moderate range of sleep apnea, and you certainly have bad consequences once you get into the severe range. Really in that mild range, there's not really much data to support poor health outcomes, but it can make people it can make a certain group of patients very symptomatic from their sleep apnea. So a lot of times if someone has mild sleep apnea, and they don't feel particularly bad, I might just, you know, talk to them about, you know, weight loss, fitness. Sometimes they just need a little positional therapy and they might not necessarily go on treatment. But once you start getting into that moderate range, that's when you really start, you know, getting concerned they're going to have a heart attack, stroke, pulmonary hypertension. You know, our division chief has done a lot of work in COPD and heart failure, and he just actually published a study looking at COPD and COPD readmission rates, and, you know, untreated sleep apnea in the COPD patient is actually a pretty serious finding based on his recent work. So very interesting. Next slide. So what do you guys think here? We talked about this a little bit. If you had to pick a pressure, what do you think this patient did best on?
Feel free to unmute or chat in and I can read it off for you as well.
I would say the BiPAP of 16/14.
Very good, Allison. Yeah, very good. So, yeah, you can see here next slide. Oh, yeah, here we go. Sorry. It's been a while since I gave this talk. And I think it's probably, you know, there was probably, go ahead and go to the next slide. I think I hit it again. Yeah. So you guys can see here, I mean, I would call that a win, right? Look at that. 45 minutes, slept for 40 minutes, had a good amount of REM sleep, and the AHI went from 53 to 6. I would definitely call that a win. And as you can see, after we started increasing the pressure more, you can see that central apnea index started going up. And again, that's probably from over titration. And we did fix that with a BiPAP ST, but where you see the backup breath rate of 10, but you know, you really got the same amount of control, but there was much higher pressure. You can see the patient didn't sleep as well. And again, you're using a $3,000 box when a $500 box would do the trick, right? So next slide. So again, the pathogenesis of this complex or treatment-induced apnea is not completely understood, but we do think it's related to alterations in CO2 excretion, and as the airway becomes more patent, you know, you start more efficiently removing CO2 at night, and your CO2 drops below your apneic threshold and you don't breathe. There's also a phenomenon called glottic braking, where you give these really high pressures to the upper airway and you get paradoxical movement of the vocal cords, which sort of gives you this upper airway obstruction, and an obstructive sleep apnea type picture, actually, because you get this reflex of the vocal cords, but then it also cuts off your sort of spontaneous respirations. It was described by an ENT actually in California. Next slide. And as I said, a lot of these cases, though they will resolve over several weeks, the complex apnea types. And one thing to keep in mind, if you're seeing a patient with obstructive sleep apnea, their apnea does tend to resolve or improve over time as the upper airway edema and swelling goes down and you treat them. So, you know, you might see on their first night of treatment, their residual apnea hypopnea index is, you know, 17. And you like, wow, they're still in that moderate range. You know, we do worry about health problems in that moderate range. But, you know, if you looked at them again in another 4 weeks, 6 weeks, they might be, you know, their apnea may have dropped to 5, or will certainly be in the mild range at that time. Some individuals may have underlying idiopathic central apnea. That's actually a fairly rare condition, but, you know, we have occasionally seen that where they have mostly central apnea and you don't really know why. Many times these patients will do an MRI on to make sure they don't have some brainstem problem or Chiari malformation or something like that. But you do this full workup and you don't find anything. With the opiate crisis in West Virginia, always remember that these patients get who are chronically use opiates actually have really difficult to control central apnea. And it actually can lead to pretty bad seat fragmentation in these individuals, which is interesting. That's one group. A lot of times I may even consider adaptive servo ventilation. You know, we've kind of moved away from ASV from some data showing that patients with heart failure do worse with that. But if they have a preserved ejection fraction, you know, that is a group I will consider using ASV on. And then Shane Stokes respirations, which is that crescendo, decrescendo pattern of breathing. You see it most commonly in heart failure patients, and it's really described with this engineering term of high loop gain, where, you know, we see it in heart failure because there's a prolonged circulation time. So it takes, you know, your red blood cell a long time to get from the left atrium all the way around your body and back to that left atrium. That's how you can think of it. And so changes in your blood gas take a while to get to the central, the central nervous system and your respiratory centers to respond. So, you know, we had this very complicated device, an adaptive servo ventilator that would, you know, essentially give full support while you were in your apneic phase, and then when you were hyperpnic, it almost sort of turned off and really kind of smooth that breathing out. But it turned out we were probably killing people with that based on the SERVE-HF trial, so we don't use that device too much anymore. Next slide. And again, the over titration, you know, just like I said with the, you know, complex central apnea and treatment-induced central apnea. Again, we don't know too much why this occurs. We do know of this phenomenon of glottic braking and then washing out the CO2 from the anatomic dead space and more efficiently removing CO2. There's also the sort of, you know, overactivation of the lung stretch fibers, which sort of gives feedback to this respiratory centers that the lungs are being overdistended, and, you know, cuts off your breathing that way. But again, these are not definitive. One of the old presidents of the ATS, Tool Malhotra, has written a lot on this, actually. It's pretty interesting if you guys are ever looking for some papers on it. Next slide. So this patient that Allison prescribed BiPAP 16/14 came back 6 weeks later. You can see that doing great, using the machine every night for more than 4 hours, getting 7 hours of sleep a night, and the residual AHI is now in the normal range. So home run patient. Next slide. So now we have a 68-year-old patient with a history of hypertension and small stroke coming in for a second opinion of management of obstructive apnea. She was originally diagnosed with OSA 6 months ago based on an out-of-center sleep test that showed an AHI of 26. The central apnea index was 7. She was prescribed an auto CPAP trial at home, didn't do well. Subsequently underwent a titration study and was initiated on BiPAP at 12/8. Next slide. She reports feeling marginally better on BiPAP therapy, but still sleepy at times. Her Epworth is 16. And this is a fairly well-validated subjective assessment of sleepiness. So over 10 is considered significant. So she's fairly sleepy. You can see that she's using her machine very well, but she's still having a fair amount of respiratory events. And most of these devices will try and differentiate between obstructive and central apnea. They call them clear airway apneas because when they're using this machine, a central apnea is defined as no respiratory effort. So these patients don't have belts on or no way to check that. The way the machine checks it is it looks for a decrement in airflow. And if there's no airflow, it gives a little burst of pressure. And if there's no resistance, meaning the airway's patent, then it calls it a clear airway apnea, which is akin to a central apnea. So you order a retitration study. Next slide. So again, you can see patients on PAP therapy, there's no airflow. You can see in the chest and abdominal belts, there's no respiratory effort ongoing. And then you see this microarousal. So up top on the EEG, you can see how the EEG speeds up, becomes more prominent, and that's leading to an awakening. Next slide. Next. So what could you do here? Next slide. So this is someone I'd probably put on a BiPAP ST. This was an actual patient I saw in clinic, and I think she had a stroke that, from what I recall, there was some sort of brainstem involvement, and we thought it might be affecting her respiratory centers. And you can see that, one thing to keep in mind about central apnea, there's not as much, doesn't seem to be as much consequence as far as health goes. You don't get these big swings in thoracic pressure. There's not a big increase in sympathetic tone. They don't tend not to get as hypoxemic, but these central apneic events can lead to recurrent arousals during the night and make people feel really crappy. So that's, and as you saw in the example I gave you, you could imagine that happening, multiple times every hour throughout the night. You just keep waking up and waking up and waking up. You would feel, pretty run down. So the idea would be in this patient, adding that backup breath rate would decrease these microarousals and they'd get better sleep. And that's what happened in her. She came back 2 months later, was using her new machine even better, and her AHI was much better controlled, and her central apnea index, her central apnea is almost, or clear airway apnea is almost resolved. Next slide. Just the reasons bilevel therapy will fail, and this is true even in the hospital when you're taking care of these people acutely, is they'll get significant mass leak. You can get sort of patient ventilator dysynchrony. And remember those, things we discussed, the rise time, the TI time, the trigger, the cycle. Those might be things you need to modify on your device when you're treating one of these patients. Is the pressure, are they just intolerant of the pressure? And that can be very common, particularly in people who are naive to one of these devices. And, even though 16/8 might be ideal for these patients, to get them used to it, you might have to start with 10/5 or, 10/8 or something, just kind of slowly work them up to a pressure that's probably more appropriate. Or is it the wrong mode for pathology? This is, and sometimes we certainly see this, particularly in like neuromuscular patients. I think I have a case showing, I got one more case left, right? Next slide. Oh, this is just showing, this is a friend of mine, Luke Donovan, published this, just showing that these abnormalities in the airflow that are occurring, next slide, that they picked up on. And it was really just from mask leak, and airflow normalizes just with the addition of a chin strap. Next slide. We'll keep moving here. Is that, I wasn't paying attention to the time. Did Dr. Doyle get on?
Hey, Dr. Stansbury. Yeah, Dr. Doyle is on, but he is going to be presenting his case for next time.
Oh, sorry. I lost pressure.
No, you're good to go. You're totally fine. Thank you.
Again, this is just sort of reiterating what we saw before. Next slide. So this was an interesting kiddo I saw. He was referred for a bilevel trial. He had really severe apnea at baseline, an apnea hypopnea index of 123. He underwent a tonsil and adenoidectomy in a trial of CPAP at an outside lab. His CO2 levels were actually found to be in the 80s with hypoxemia and very prolonged apnea. They had actually used the BiPAP S and BiPAP ST on him. Really struggled controlling his apnea. He was, doing very poorly in school. His parents said, there were times they were worried he was going to die at night. Next slide. And this is what we found in this kiddo. So when we saw him in clinic, we took a history, and he had this whiplash injury 3 years prior that, the doctor said he was fine. He walked into my clinic and he had this like shuffling gait, was very weak. We got an MRI, and you can actually see there was injury impinging on his brainstem here on that blue, where that blue arrow is. So he actually underwent surgical correction, was in a halo for a couple years, where they tried to sort of get some of the scar tissue out from around the brainstem. And we actually brought him into the lab and put him on a home ventilator, which he did much better on, started doing much better in school. It did take about 2 years, but thankfully, very young kids, their CNS has pretty good plasticity and regenerative properties. So he's almost back to normal now. He was on one of these home ventilators for 2 years and had to have kind of a couple pretty big surgeries with our neurosurgery colleagues to get this corrected. Next slide. So I think, understanding the basic function of these devices and secondary devices can be very helpful in optimizing therapy for your patients. And it's true in sleep apnea, central apnea, but I think it's also true when you're, taking care of patients with advanced COPD or neuromuscular disease, really trying to tailor therapy to the individual patient. Remember, perfect is the enemy of good. So, no therapy is effective if the patient is not going to use it. So you want to make sure that, you're doing something that's sort of targeting the underlying pathology, but you also got to make sure that it's something the patient's happy with. And you guys don't necessarily have to know the guidelines for your bi-level titration or your local protocols, but most hospitals may have some protocols in place on how you titrate these devices, and it's probably worth knowing that when you're taking care of acutely ill patients on non-invasive ventilation. And then, if a patient's not doing well on one of these therapies, they're very effective. So you should really consider, why are they not doing well? Why are they failing therapy when they're not with the treatment you have them on? So, next, I think that's it.
Thank you so much, Dr. Stansbury. Really appreciate it. Great presentation as always. We have about 7 minutes left. Did anyone have any questions, comments, or thoughts that they wanted to share with the group? Feel free to unmute.
I have a question, Rob.
Yeah.
This is Allison. Could you explain a little bit about the modalities that you were talking about today and where the Trilogy fits in? Because I know a lot of people probably in this group are familiar with the Trilogy ventilator. Is that one of the ones that you talked about, or how is it different?
Yeah, so the Trilogy ventilator, so when you talk about home ventilation, that's a completely sort of different new set of worms. Those devices are extremely expensive. There was a few years ago, there was actually some lawsuits where DME companies were giving RTs kickbacks when they identified someone who needed a Trilogy ventilator, because the DME companies make a killing. They're like, $5,000 to $10,000 depending, and then they send someone out monthly to maintain these ventilators, which is another $1,000 or something they get a month. That being said, there are certainly patients who benefit greatly, I think, from home ventilation. And what you can do with the Trilogy, one is, you have the ABAPS mode, which is a volume assured pressure support, where you really are, providing respiratory support at home, maintaining a patient's minute ventilation, very effective. The Trilogy ventilator also has a ABAPS AE mode, where it titrates the IPAP or pressure support to target that tidal volume. Then it'll also titrate the EPAP to take care of any comorbid sleep apnea they have. So it really does everything you want it to do. The other really nice thing about the Trilogy, and why I use it a lot in our neuromuscular patients, and I say we use it mostly in our COPD patients now too, is you can put a sort of night mode on it and a day mode. So you might put them on sort of full ventilatory support at night, and then if a patient's using like mouthpiece ventilation during the day, they hit a button and it switches to that new mode for mouthpiece ventilation. Now the Trilogy is the one I think most companies around West Virginia are familiar with. But I will say the RemStar device, which is a ResMed device, is another home ventilator. I will say it has a much better user interface for patients. It seems a lot simpler to use to me. It doesn't have a lot of the bells and whistles that the Trilogy does, but I think the problem with that is the folks who go out and maintain these devices aren't as familiar with it, so they can't troubleshoot it as well. So that's why I think a lot of times we end up going with the Trilogy, even though I do think the sort of RemStar device by ResMed is really nice too.
Thank you.
Any other comments, thoughts, or questions?
Sorry I took up your time, Dr. Doyle.
No problem.
Dr. Doyle, we have to find that sweet spot for you again so we can hear you with the audio.
No problem. No problem. No problem.
We got it. Thank you. Yeah, the roads were icy today, so we appreciate you, Dr. Doyle, for being flexible and being able to present it next time.
One thing
All right, well,
to add to Allison's question, I think when you guys are looking to put someone on one of these devices, you know, sleep apnea is very, you know, a very common diagnosis, but you know, there are qualifying guidelines for COPD, obesity, hypoventilation syndrome, neuromuscular disease. And when you're looking to qualify someone, they, you know how Medicare is in the government. They can't call it like bi-level therapy, so they call it. You got to Google guidelines for respiratory assist device. And so if you're looking to like discharge someone on, you know, BiPAP or even like a BiPAP ST, if you Google that, it gives you like very specific guidelines. One trick you can use, you know, I try not to overuse this, but if it's true, it's worth writing, is, you know, if you write chronic respiratory failure as, you know, your diagnosis, you can get someone anything you want, essentially, whether it's a home ventilator or a BiPAP machine or whatever. But
Hey,
Dr. Doyle, it's a little difficult to hear you.
how about here?
That's better, yep. It's difficult to hear you again. It might be if you have like a cell phone near you, sometimes moving that away for some reason helps. Feel free to chat it as well. I can read it off for you.
He might be coming to my computer. Can you hear me?
Yes, we can hear you. Yep.
Okay.
Oh, the headphones. Good call. It might be the network connection in that room specifically. That happens to me in my too.
But can you hear this?
That's perfect, yes.
My question was, Dr. Stansbury, on the topic of chronic respiratory failure, what's your rigorous definition of chronic respiratory failure?
yeah, so there's not a well-defined definition. You know, recurrent, I think if someone is admitted for recurrent COPD exacerbations with hypercapnia, that's a lot, you know, a lot of times. And then they have, you know, PFT findings that show severe obstruction. That's one that comes to mind quite commonly. A lot of our ALS patients, you know, I think for them, you have to have a CO2 level greater than 45, and then their FVC has to be less than 50%. That's another one that comes to mind. A lot of patients with like pexis excavatum or severe scoliosis, or, you know, any sort of thoracic cage abnormality, if they have an FVC that's less than 50%, you can use that diagnosis. Those are ones that kind of come to mind.
Thanks.
Alrighty, guys, we are at the end of our session hour. So I just wanted to thank you, Dr. Stansbury, for the great presentation and super useful information in there. So we truly appreciate it. And as always, we thank all of you guys for joining as well. It's always nice to see you guys. So the only announcement I have is that our next session will be on March 1st, and Dr. Zulfikar will be discussing Intro to Interventional Pulmonology. So keep an eye out for that reminder. Dr. Doyle will have a case to present for next time as well, so we're super thrilled about that. And we'll see you guys next time. Thank you.
Take care, guys.
Bye.